Hello dear students, welcome to this class on diabetes in pregnancy. So basically we will be talking about gestational diabetes in this class. What actually do you mean by gestational diabetes mellitus? Gestational diabetes mellitus refers to diabetes in pregnancy, which is a hyperinsulinogenic state. So at the very onset, you should remember that pregnancy is a diabetogenic state. Pregnancy is a diabetogenic state. Diabetogenic state. Now, why is it said that pregnancy leads to diabetes? This is because of various reasons. Number one, the first reason is because insulin resistance occurs in pregnancy. Insulin resistance occurs in pregnancy. This is a normal phenomenon that in pregnancy patient will develop insulin resistance. Why this is so? This is because of three reasons. Because the placenta is secreting human placental lactogen. Human placental lactogen is a hormone which is antagonistic to insulin. It will stop the action of insulin, so sugar levels will go high. Number two, increased production of cortisol. Number one, increased production of cortisol, increase in the amount of estrogen and increase in the amount of progesterone are also having an action which is contraindicating the action of that is, it is acting against the action of insulin, so it is leading to insulin resistance. And number three, there is destruction of insulin. Destruction of insulin, the body's insulin, by the placenta and the kidneys. By the placenta and the kidneys. Now, why destruction of insulin is occurring in the placenta and kidneys? Because placenta and kidneys are secreting insulinase enzyme. Insulinase enzyme. And insulinase enzyme is destroying the body's insulin levels. So because of all these three reasons, one is the human placental lactogen secretion, then increase in the amount of cortisol, estrogen and progesterone. These are acting antagonistic to insulin, and moreover the insulin which is present in the body is destroyed by the placental and renal insulinase enzyme. Apart from that, pregnancy is also a diabetogenic state because lipolysis occurs in pregnancy. Increased lipolysis will break down the lipids in the body, and the breakdown of lipid will lead to production of glucose in the body, and glucose, increase in glucose will also lead to diabetogenic state. And moreover, there is increase in gluconeogenesis. There is increase in gluconeogenesis which will again increase the glucose content, and so thus pregnancy is called the diabetogenic state. Because pregnancy में diabetes common है, that is why it is very important to read about gestational diabetes mellitus. So what actually is gestational diabetes? You have to differentiate from it from overt diabetes. What is overt diabetes? Overt diabetes is also called pre-gestational diabetes. Pre-gestational diabetes means diabetes which was already present before pregnancy comes under overt diabetes or pre-gestational diabetes. It can be either type 1 diabetes or type 2 diabetes. So in medicine classes, you all have studied about type 1 and type 2 diabetes mellitus. Type 1 diabetes mellitus mein it is basically the deficiency of insulin. When the insulin level is low in the body, it is less secreted, then it is type 1 diabetes. Whereas type 2 diabetes occurs when there is insulin resistance, means insulin is there in the body, perhaps insulin level is very high in the body because the receptors of insulin and the organs in which insulin is acting is not, the receptors are low, that is the insulin is not able to act. So if the patient is having diabetes from before pregnancy, it will be pre-gestational or overt diabetes, whereas diabetes detected first time during the pregnancy, is termed as gestational diabetes mellitus. Okay, so let us focus upon GDM. नाउ इट इज़ सीन दैट इट मे सो हैपन कि पेशेंट पहले से ही डायबिटिक थी, लेकिन वो पहले से कभी टेस्ट उसने नहीं कराया एंड वो फर्स्ट टाइम उसने प्रेगनेंसी में टेस्ट कराया एंड उसका शुगर्स हाई हो गया. देन व्हाट विल वी से? फॉर द टाइम बीइंग वी विल term the patient as gestational diabetes mellitus, and we will again test the patient in the postpartum period, that is after 6 weeks postpartum. 6 weeks के बाद we will get the sugars done. If within 6 weeks postpartum the sugars normalize, then our diagnosis of GDM is established. But after 6 weeks also sugars are high, then actually this patient is a case of pre-gestational diabetes or overt diabetes. Now actually what happens, the incidence of gestational diabetes, that is GDM, is high after 24 weeks of pregnancy, that is 24 to 28 weeks of pregnancy, that is 6th to 7th month of pregnancy. Hyperglycemia is at its highest. Why this is so? This is because the placental mass is maximum developed at 24 to 28 weeks period of gestation, and so your secretion of human placental lactogen and human chorionic gonadotrophin and your cortisol and everything will be highest during this time. Okay, cortisol, they will be highest during this time. So insulin resistance is also highest at 24 to 28 weeks. Okay, so GDM incidence is highest at 24 to 28 weeks, but you cannot say that 24 to 28 weeks में होगा तभी उसको GDM बोलेंगे. First time in pregnancy, even if it is diagnosed in the first trimester, then also we will say कि it is gestational diabetes mellitus. Okay. Now what are the diagnostic criteria for gestational diabetes mellitus? What are the diagnostic criteria? Okay, very important question. What are the screening criteria or diagnostic criteria for gestational diabetes mellitus? Okay, what are the screening criteria? So there are various bodies like American College, the NICE guidelines, Indian guidelines. Everybody, WHO have different modalities of diagnosing GDM. Okay, so first let us go with the primitive, that is American College of Obstetrics and Gynecology. What the screening modality is in America? In America, diagnosis of GDM or screening for GDM is a two-step procedure. It is a two-step process. By two-step process, we mean that patient will be screened 2 times in pregnancy. So the first step, what we will do in first step? In first step, we will go for a test which is called the O'Sullivan test. O'Sullivan test. O'Sullivan test is also called the glucose challenge test, GCT. O'Sullivan test is called the glucose challenge test. So every patient will be subjected to 50 grams of glucose. 50 grams of glucose पिलाएंगे patient को, dissolved in 200 to 300 ml of water. 200 to 300 ml of water you will give to the patient, and then you will check the blood sugar after 2 hours. After 2 hours of drinking this 50 grams of glucose, you will measure the blood sugar level. If the blood sugar level is less than 140 at 2 hours, then you say to 140 milligrams per deciliter blood sugar level, then you say patient is normal and she is not gestational diabetes mellitus. Okay, but if the sugars are more than 140, if the sugars are more than 140 milligrams per deciliter, then you have to tell the patient for second step process. Okay, so you subject the patient to second step testing. Second step testing I will tell. Okay, but if the value is very high, that if the value is more than equal 200 milligrams per deciliter, then you straightforward tell that the patient is gestational diabetes mellitus, and second step testing is not required because sugars are already very high. You need not to give glucose anymore because glucose challenge से बार बार उसके sugars और बढ़ जाएंगे. So patients who have in the O'Sullivan test have sugars between 140 to 200, they will be subjected to the second testing. Now what we will do in the second testing, we will call the patient after 2 to 3 days for the second testing, and this second testing is called the Carpenter and Couston method of testing. Carpenter and Couston, Couston criteria. So Carpenter and Couston criteria is done in patients who have 140 to 200 in the first step. So Carpenter and Couston says that you first take a fasting blood sugar, then you give 100 grams of glucose. Now you are giving a higher challenge, that is 100 grams, double the dose you are giving. And then after 1 hour you are taking one blood sample, after 2 hours you are taking another sample, and after 3 hours you are taking the blood sample. So 4 samples have been taken in Carpenter and Couston criteria. If the fasting is more than equal 95 milligrams per deciliter, these are the cutoffs which are taken. 1 hour is more than equal 180, 2 hours is more than equal 155, and 3 hours is more than equal 140 milligrams per deciliter. These are the criteria which are taken. So if 2 out of the 4 criteria are met, means 2 out of these 4 are satisfying, then we say patient is gestational diabetes mellitus. If 1 out of the 4 is there, then the patient is not diabetic, and if none of the values are above this value, then the patient is not diabetic. So this is what the test is done in America, American College of Obstetrics and Gynecology. They have very much resources, high resources country, so they can do 2-step testing for screening of diabetes. Okay, this is sometimes followed in some of the hospitals of India also. The second criteria which we have, which used to be followed in our country till 2018, we used to rigorously follow this criteria, is IADP-SG. IADP-SG or WHO criteria. WHO has taken this IADP-SG criteria into consideration. IADP-SG is International Association of Diabetes in Pregnancy Study Group. I am revising once more. It is International Association of Diabetes in Pregnancy Study Group. So it is an international group which this study was done late in 1992. It was started and it was carried out in all countries of the world including India, and then WHO had taken this study into account. So this tells that it should be a 1-step test rather than a 2-step test, because in 2-step patient will be lost to follow up and patient के पास इतना पैसा भी नहीं रहता है. So resource poor countries like India cannot afford a 2-step test. So IADP-SG test used to be done in India till 2018, whereby we give 75 grams of glucose to the patient. 75. We are not going to 50, we are not going to 100. बीच वाला dose 75 grams of glucose देते हैं patient को, dissolved in 200 to 300 ml, that is 1 glass of clear water दे देते हैं patient को. So we take a fasting sample before giving the glucose solution. We take a fasting sample. Before fasting sample, the fasting should be of 8 hours, very very important, but it should not be more than 14 hours. So 8 to 14 hours of fasting is required, overnight fasting is required, and then we take the fasting sample. After that we give 75 grams of glucose, and we take the sample, blood sample, after 1 hour and after 2 hours. So fasting, 1 hour and 2 hour are the 3 samples which are taken. In this IADP-SG guideline, the cutoffs taken are 92 milligrams per deciliter and below should be fasting. If it is more than equal 92, then patient is GDM. If 1 hour is more than equal 180 milligrams per deciliter is the cutoff taken, and 2 hours is taken to be 153 milligrams per deciliter. So these are the cutoffs taken. Okay, so fasting, it was 95 in ACOG, here it has reduced to 92. The 1 hour was 180, it is same in IADP-SG or WHO also, and the 2 hour was 155. 3 hour has been omitted, so many samples are not being taken, and 2 hours is being reduced from 155 to 153. So if any one of the values, any one out of 3 is abnormal, then you say patient is GDM, that is gestational diabetes mellitus. So this is a very easy step and it can be done as one step procedure. But patient has to come fasting for 8 to 14 hours. Now what happened, Indian government has said that we should not keep our antenatal patients fasting, because fasting may there is very high chance of ketoacidosis and then very high chance of intrauterine fetal death. So what we have lately started is the DIPSI guideline. DIPSI guideline, it has come first in 2018 and since then it has been followed. So DIPSI is Diabetes in Pregnancy Study Initiative or Study Group of India. It is DIPSI guideline is of India, Diabetes in Pregnancy Study Group of India. So DIPSI guideline is specific for Indian population only. So what DIPSI guideline is saying, very important, remember, patient should never be fasting. Pregnant patient को कभी fasting नहीं रखना है. So patient should not be told to come fasting to the OPD. So what we do is, irrespective of fasting status, whenever an antenatal mother comes to OPD, you give her 75 grams of glucose. Okay, 75 grams of glucose is given to the mother. Now this 75 grams of glucose which is given to the mother takes it dissolved in 200 to 300 ml of water. 200 to 300 ml of water. So mother takes 75 grams of glucose, 75 grams of glucose dissolved in 200 to 300 ml of water, just like IAD-PSG guideline. But the difference is that mother will not come fasting, whereas in IAD-PSG patient used to come as fasting. So 75 grams of glucose is given to the mother irrespective of fasting status, and then you take only one sample, one blood sample, which is done after 2 hours. 2 hours बाद एक sample कराना होता है. Now what are the questions which come over here? 75 grams of glucose देना है, कितना water में dissolve करके? 1 glass, 200 to 300 ml of water. Patient should be drinking this water in 5 minutes to 30 minutes. Between 5 to 30 minutes she will be drinking the water. Preferably 5 to 10 minutes के अंदर, 5 to 10 minutes के अंदर she will drink the water. Okay, always write, if the answers, if somebody is asking you in exam, try to mention it 5 to 10 minutes, because the preferable is 5 to 10 minutes. If patient has vomiting, अगर उसको vomiting हो जाता है in first 30 minutes, in less than 30 minutes अगर उसको vomiting हो जाता है, then repeat the test next day. Repeat the OGTT. It is also called OGTT, oral glucose tolerance test, or it is also called GCT, glucose challenge test, or DIPSI guideline. So repeat the test the next day. Ask patient to come next day, irrespective of fasting. घर से खाना खा के भी आ सकती है, ठीक है. तो vomiting in first 30 minutes, repeat the test next day. If vomiting occurs after 30 minutes of intake of glucose, then you will not repeat the test and you will move ahead with the test, and 2 hours बाद आप glucose, plasma glucose measure करेंगे. Okay, because in first 30 minutes the glucose has already been absorbed into the blood. तो अगर उल्टी हो भी जाता है, अगर vomiting हो भी जाता है, तो it will not hamper the glucose challenge. Okay, so 2 hours बाद take capillary blood. We will not ask the patient to give venous blood sample. We will ask to give capillary blood, is done with a glucometer. This is because it is easy. Glucometers are available in every PHC, CHC has glucometers. So a finger prick glucometer will be enough to check the blood sugar level. If the blood sugar level is more than 140, if it is more than equal 140 milligrams per deciliter, 2 hours after taking the glucose challenge test irrespective of meal, then we say patient is GDM, gestational diabetes mellitus. Whereas if the value is less than 140, then we say patient is normoglycemic and she need not to repeat the test. Now, at what gestational age do you do this test? This test can be done any gestational age, any gestational age. DIPSI has made this guideline into any gestational age because many of the poor people in the villages come for only one antenatal visit. कभी भी एक बार बस आती है, वो बार बार नहीं आती है. अगर if you do not perform the test and if you ask them कि 24 weeks पे आना, तब वो कभी आएगी ही नहीं. फिर वो डिलीवरी कराने आएगी and we will not be able to detect diabetes. So whenever a patient comes to antenatal OPD, to gynae OPD, we give her 75 grams of glucose irrespective of her fasting status, and then you do the DIPSI guideline test. Now this is very important, what changes have come in DIPSI. Okay, so one step test is done, and if value is more than 140, you diagnose as gestational diabetes mellitus. Okay, always remember this 75 grams of glucose what you are giving is actually anhydrous glucose. Okay, so this is a special packet of glucose that comes in the primary health centers and CHCs. But suppose this anhydrous glucose is not available and you ask patient to get Glucon-D from the market, Glucon-D. Now Glucon-D is not anhydrous, it is monohydrated form of glucose, monohydrated form. तो हमारे जो मार्केट में अवेलेबल होता है, those are monohydrated forms of glucose, and so that will not be 75 grams, that equivalent of Glucon-D will be 82.5 grams. So if you are giving Glucon-D, then you have to give 82.5 grams, which equals to 75 grams of anhydrous glucose. Very, very important, asked in examination. Now this is the diagnostic criteria. Now the thing is, question when it comes screening for diabetes, then you have to tell the ACOG 2-step criteria, the IID, PSG, WHO, and then the DIPSI guideline. All you have to say. But who are the patients in whom you will be screening? कौन से patients को screen करना है diabetes के लिए? In India, remember, we have to go for universal screening for diabetes. Universal screening. इसका मतलब है every patient, every antenatal patient who comes to our OPD, irrespective of fasting status, and even if it is the first visit, you have to go for screening for diabetes. But there is high risk category and moderate risk category whom you have to screen apart from universal screening. This means if it is not in Indian country, not in Indian context, other countries, मान लो America and Europe, they have their other guidelines who are the high risk and moderate risk patients. This is very important. Remember, patients who have obesity, that is BMI more than 25 is pre-obese and BMI more than 30 is category 1 obese. They will be screened for diabetes. Okay. Then previous history of GDM, previous history of gestational diabetes mellitus था, तो इस बार also we will screen for diabetes. Okay. Then history of macrosomic baby, previous baby delivery हुआ था and baby had a weight more than 4 kg. So this time we will screen her, of course, for gestational diabetes mellitus. Then if there was congenital malformations in the baby, history of congenital malformations in the baby. Now why congenital malformations occur in diabetic patients, this I will be telling in a few while. Then if there was any history of instrumental vaginal delivery, or there was shoulder dystocia, that is बच्चा फंस गया था, बच्चा बड़ा था, ये सारे अगर हिस्ट्री है, और if patient was having any bad obstetric history because any infantile death था या कोई stillbirth था, तो these are high risk patients and they should be always screened for GDM. Also patients who have type 1 or type 2 diabetes mellitus in their family members or if they are having recurrent candidal infection, candidiasis, then they are at high risk of diabetes and they should be screened. The moderate risk factors include the Indian population. Indian population, all Indians are having moderate risk, so they should be screened for diabetes in pregnancy. Age more than 25 years. Age more than 25 years is a moderate risk factor. Then overweight before pregnancy. Overweight, or that is obesity before pregnancy. Overweight before pregnancy and obesity during pregnancy is a high risk factor. Then diabetes in first degree relatives, first or second degree relatives. Okay, in relatives में history है, okay, then they are moderate risk factors and they should all be screened for diabetes. In India, of course, everybody should be screened for diabetes. How you should be screening, that I have told. Now always remember, in pre-gestational diabetes, let us talk about HbA1c. Pre-gestational diabetes जिनको है, मतलब जिनका पहले से ही शुगर्स रेज्ड है, देन उनका क्या होता है, फर्स्ट ट्राइमेस्टर में एट द टाइम ऑफ ऑर्गेनोजेनेसिस, वेन एवर देर इज ऑर्गेनोजेनेसिस या फिर ऑर्गन्स आर बीइंग फॉर्म्ड ड्यूरिंग द फर्स्ट 7 to 9 वीक्स, फर्स्ट 7 वीक्स तक जब ऑर्गन्स फॉर्म हो रहा है उस समय पे दे आर हैविंग हाइपरग्लाइसेमिया. So their HbA1c is raised at that time. HbA1c is raised at that time. So organogenesis will not occur properly and there will be midline defects in the baby, that is neural tube defects, NTD. So neural tube defects are very common in mothers who were already pre-gestational diabetes. So what is the incidence of congenital malformations? Remember, if HbA1c is less than 6.5%, then the chances of congenital malformations is 2 to 3%, which is the baseline congenital malformation risk in our Indian population. That is, अगर शुगर्स नॉर्मल है तो 2 to 3% रिस्क है कि congenital malformations होगा. वही अगर HbA1c is more than 10%, then the risk of congenital malformation increases to 22% in pregnancy. So always remember, if patients are pre-gestational diabetes and their HbA1c is very high in the first trimester itself, then you can ask the patient to go for medical termination of pregnancy because the congenital malformation risk is very high. But if the patient is not willing for medical termination of pregnancy, then you have to explain that we will go for aneuploidy screening and level 2 ultrasound and we will try to look for congenital malformations, basically neural tube defects in the babies. Okay. Now what are the congenital malformations which generally occur in babies of mothers who are pre-gestational diabetes? Very important questions always come from this topic. Congenital malformations which are very common and very specific to infants of diabetic mothers. So always remember, this occurs in overt diabetes or pre-gestational diabetes, not in GDM of course. GDM में अगर later half में अगर pregnancy में sugars बढ़ रहे हैं, when HPL and HCG are high, that is at 24 to 28 weeks, so by then already your organs have been made, so organogenesis is not hampered. At that time it will be macrosomic baby or shoulder dystocia, ये सारा होगा polyhydramnios, but not congenital malformations. Congenital malformations occur in overt diabetes patients. So coming to the cardiovascular system. Cardiovascular system may always remember, the most common defect is VSD. Ventricular septal defect is the most common cardiovascular anomaly which is found in patients of infants of diabetic mothers. Okay, VSD is most common, whereas most specific disorder, congenital malformation in the CVS is transposition of great vessels. Transposition of great vessels is the most specific, whereas VSD is most common. So this is very important. Apart from that, you also have HOCM, hypertrophic cardiomyopathy, and also hypoplastic left ventricle. Hypoplastic left ventricle is also found in patients or in infants of diabetic mothers. Okay, so these are the cardiovascular system. Then coming to CNS abnormalities are also very common, of which neural tube defect abnormalities are very common. उसमें से you can have your anencephaly. Anencephaly can be there, whereby the head is not formed, the cranial vault is not formed, or there can be spina bifida, whereby the spinal cord is divided into two. Then there can be meningocele, encephalocele. Okay, so these are the abnormalities which can be there. There can be microcephaly, that is the head is very small, or there can be holoprosencephaly. Okay, so these are some of the abnormalities, of which always remember the most specific CNS disorder in babies or infants of diabetic mother is caudal regression syndrome. Very, very important, and this question comes very often. Caudal regression syndrome, which is also called sacral agenesis. Sacrum is not formed properly. So this is the most specific CNS disorder which is seen in babies of diabetic mother. Also, the most specific of all disorders is caudal regression syndrome, followed by transposition of great vessels. Okay, coming to your renal system. In renal system, what are the abnormalities which can be found is there can be absence of kidney, unilateral or bilateral kidneys. There can be polycystic kidneys, not polycystic ovarian syndrome, of course. Polycystic kidneys can be there, and there can be duplication of ureter. Means there are two ureters can be found in the renal system. Duplication of the ureter can be found. Okay, apart from that, there can be gastrointestinal system can be abnormal, that is the GI system can be abnormal. Okay, now what are the GI system abnormalities which can be found? GI system abnormalities can be in the form of tracheoesophageal fistula, imperforate anus, and bowel atresia. So these are some of the abnormalities which can be found.